Hello, I'm Kathy Bowles. I'm a professor of nursing and the Van Amerongen Chair in Nursing Excellence at the University of Pennsylvania School of Nursing. I'm also the director of the Center for Home Care Policy and Research at V&S Health in New York. I'm a member of the American Academy of Nursing, and I'm also a fellow in the American College of Medical Informatics. I want to tell you today about my program of research. I feel like I've come full circle in my career. I started out as a critical care nurse working in ICU, and many of the patients I took care of had developed sepsis. Sepsis is a life-threatening infection that results in organ dysfunction or organ failure due to the immune system's over-response to the infection. These patients are very, very ill, and they have a long, long time for recovery. And I always enjoyed the challenge of taking care of them and helping them survive this terrible illness. So my current program of research moves into taking care of these patients after a hospital discharge. Now, sepsis affects about 50 million people worldwide, and it causes more deaths than prostate cancer, breast cancer, and AIDS combined. So it's a very, very serious, deadly disease. Greater than 60% of the patients who are diagnosed with sepsis are older adults. And so my program of research does focus on older adults. It always has, and this is a very important topic for this population. Sepsis is the most common cause for an intensive care unit admission, and 30 to 60% of patients with sepsis in the ICU die. Of those who survive, we are studying those that go to home health care. Patients who survive sepsis are 2 times more likely than other patients to be readmitted to the hospital. And in home care, among those who are readmitted, 32% of those readmissions occur in the first week. Our program of research is called I-Transfer. It stands for Improving Transitions and Outcomes of Sepsis Survivors. And what we are doing is implementing or putting into practice a protocol that demonstrated that if we give early attention to sepsis survivors once they get home in that very first critical week, they have a reduced readmission rate of 7 percentage points lower than patients who don't get that kind of attention. We're working with 16 hospitals across the country and their affiliated home care agencies, 5 affiliated matched home care agencies. And what we're trying to do with them is help them implement this early visit protocol. And what that means is that they have to identify who has sepsis, communicate that this person is a sepsis patient, refer them to home health services, communicate it to home health that they had sepsis, educate the patient about sepsis, make an outpatient appointment for that patient before they leave the hospital, and activate an early visit protocol in home health where the nurse, the registered nurse, goes out to the home within 2 days of hospital discharge, visits at least one more time that first week, and we get them to the outpatient provider within 1 week. Again, patients who received this protocol had readmission rates that were 7 percentage points lower than those that did not. As we do this study, we're finding that health information technology is such a critical component of making this work. We have interviewed all the stakeholders across these 16 hospitals and 5 home care agencies to learn their current processes, to learn what are the barriers and the facilitators to doing this protocol with people. And we've learned that there are about 31 different items that come into play, factors that are either barriers or facilitators. And 38% of those are related to health information technology. Now, my program of research has always focused on technology. As a critical care nurse, I was always interested in that aspect. And now as a co-director of the Healthy Aging Core in the Penn AI Tech Collaboratory, we're really getting to see these exciting innovations come to life. So back to I-Transfer, with the health information technology challenges that we face, there are many. One of the biggest challenges we found with health information technology in our study is the electronic health record. It is such a critical piece for communication, and we discovered a problem with the problem list. So one of the things that happens in a hospital is that the physicians or providers will write the diagnoses in the electronic health record, and that carries through the record a whole way through as the patient is in the hospital and is meant to communicate to the next level of care what the patient has, what conditions they have, and will dictate then what treatments and follow-up they will need. But we discovered that with sepsis, it's an acute care condition, and it is marked as resolved when the patient is discharged from the hospital. And the health information technology challenge with that is that it falls off the active problem list, and then the next level of care may or may not recognize that this patient ever had sepsis. So we need further developments in the electronic health record to be sure that conditions that are marked as resolved are further communicated to the next level of care. Another challenge we saw is when the patient is referred to home health services to clearly communicate that this was a sepsis survivor. So we've worked with the sites to build all types of alerts and flags in the electronic health record to clearly say this is a sepsis survivor so that the nurses can activate that early visit protocol and the patient education that is needed. We've found a huge opportunity to use technology to communicate with patients and caregivers after hospital discharge. There is opportunity to use text messaging, robocalls, to do surveys electronically with patients and their caregivers after discharge to check in on them. And a really important advancement is the use of telemedicine. If we are to get these patients seen by an outpatient provider by 7 days after hospital discharge, telemedicine is a very important use of technology for that purpose. These patients are extremely weak and frail, and it's very difficult for them to get out of the home. If they're receiving home care services in the first place, it's because they are considered homebound, which means a lot of difficulty getting out of their home. So technology, bringing technology to them could be a game changer for them. I think there's a huge opportunity to use technology to improve patient education for sepsis survivors and others. We're finding in our study that many of the patients and their caregivers aren't even aware that they had sepsis or what sepsis is and what they're in for in terms of their recovery, what they need to do, what they need to watch out for. I believe that technology could be used to enhance patient education, to bring videos and other creative methodologies to the bedside while a patient is in the hospital so that they are informed of what needs to be done once they're discharged. Another opportunity is with artificial intelligence. So with my other program of research, we have developed an algorithm that identifies patients who need post-acute care services after hospital stay. And we're seeing that this could really be useful with our sepsis survivors. We see that about 15 to 20% of sepsis survivors go home with no services, no post-acute care. And it's very concerning that you could have such a life-threatening illness and not have close follow-up at home. So we love to use an algorithm like that to be sure that we are referring the right patients to the right services. Another opportunity for artificial intelligence is with natural language processing. So we see in the discharge summary a document that goes home with the patient, as well as something called an after-visit summary, which is for patient education and aftercare, that explains to them why they were in the hospital and what their follow-up should be. It would be an opportunity to use natural language processing to understand the content of those documents and enhance those documents with where information is missing that could improve our patient education and follow-up. And lastly, improvements to the electronic health record for interoperability are sorely needed. We're seeing that patients being discharged from the hospital to home health services, the communication across that chasm still needs a lot of work. We have a lack of interoperability in our electronic health records, where the nurses and the clinicians in home health care have view-only access into the EHR. And so information is gathered by them by looking into the patient's record and then things are recollected versus it being interoperable and transferred electronically. We fear there'll be errors made as they're transcribing information from one system into their system. So interoperability work is something for the future to continue to work on that, especially for transitions in care.